this is a big topic in of itself. Why does workplace violence occur? So we're going to provide you with some resources from our toolkit in Oregon. There's actually a tool that really details all the causes of violence. Why is that important for you to know? Because you really need to know how to identify the risk factors in your environment. And violence is multifactorial, and it's going to vary from setting to setting depending on the services you provide and your patient population. So we're going to kind of put these risk factors into 4 buckets. And the first one is the patient-related risk factors. No surprise here, our patients with clinical issues, they're in pain, they may have cognitive impairment. Most of the leading causes of violence are related to substance abuse and mental illness. But we have an increasing number of patients that have dementia or dementia-related diagnoses, neurological trauma, and so on. And we have to remember our patients lose control, or that feeling of powerlessness and loss of control when they're in our healthcare environments. And there are many different reasons why they may become aggressive or act out. And some of these other reasons are that they want to leave and you don't want them to leave. Patient care, they might be frightened of needles, medical devices. It could be you're transferring them, you're lifting them from bed to chair. We'll get back to that a little later. And there's situational events such as using restraints, transitions in care, or trying to redirect a patient who's left their room and you're trying to get them back to their room. And I'm sure you're all familiar with those examples. The one thing you want to think about is, though, can you prevent violence in all these cases? Because patients arrive at our emergency rooms and other healthcare environments already in a state of aggression or in a clinical crisis. So when I look at patient behavior-related risk factors, it's how do we control these so we prevent severity of the incident and prevent injury to staff and other patients and the patient themselves. Now, when we get to these other 2 categories, organizational risk factors and environmental risk factors, these are categories that employers, they can control these risk factors through design of the work environment, and we'll get back to some examples a little later, and to policy and procedure, such as, effective workplace violence prevention training, staffing, addressing issues when staff are working alone with cash or narcotics, wait times for patients, those kind of things. And environmental risk factors, where we have a noisy, crowded waiting areas, we know that's linked to higher stress levels and associated with increases in aggression. The 4th bucket, though, is social and economic risk factors. And, again, we can't prevent all of these. We can do our best to control them. So these are the things that happen in the community, as I mentioned earlier: gang violence, access to guns, domestic violence, financial stress. We can learn to work with our community partners, though. So as your workplace violence committee works on the program internally, you want to partner with your behavioral health partners in the community, emergency medical services, your sheriff, your law enforcement. All of them should be working with you so that you improve communication. So wouldn't it be nice if that patient is transported to the emergency room on a Saturday night and you have a heads up from EMS that they have been verbally aggressive or physically violent? So you have a warning and you can be prepared to control that situation. We have the revolving door syndrome you're all familiar with. Because of the decrease in mental health services, especially in rural areas, we treat our patients with behavioral health crises and then we discharge them and there's no support in the community and they come back to the hospital. And certainly in the Northwest, it may be 200 or 300 miles between a rural hospital and an urban behavioral health support center. So this is also, this was published in 2012. This is still a huge issue for us to address. I'm not going to read these in detail, but the Joint Commission analyzed their sentinel event database between 2013 and 2018, and they looked at the most common root causes of violence, and they identified them as human factors such as staffing, complacency. We just expect violence in this healthcare environment. It's just the way we do our work. Leadership. A poor organizational climate. We'll get back to that in a second. Communication failures between staff and patient. And then a lack of assessment process. How do I know if my patient's at risk for violence? Or for that case, our visitors. When it comes to bullying, we know that this is directly linked towards organizational culture. Where we have a culture that allows bullying. This is directly linked to leadership. So if you have an environment where you have laissez-faire leadership, there's no clear direction, or it's very autocratic where there's lots of rules and regulations and lots of hierarchy, we see greater incidence of bullying. And again, in a minute, I'll show you how that's tied to patient violence. Where we have a lack of autonomy and high workload, and where we perceive within nursing that we don't have competency. So my co-worker's not competent at what they do. It's nothing to do with experience. It's to do with competency for that job task at that point in time. And then I would be remiss, since I work in the patient handling world as well, not to mention the direct link between manual patient handling and workplace violence. And we have the research to support this. So obviously, if you're close to your patient, you're in that direct line of fire. You could be more likely to be grabbed, hit, pinched. I've been in that situation, especially as a student nurse. I remember it all these years later. But you think of our patients who have cognitive challenges, such as those with dementia. If you get in their personal space, it could be a trigger. We also have evidence to say that if you use overhead lifts or ceiling lifts, floor lifts, air assist devices for transfers, we see less physical violence to staff and less injuries to staff. And this is both in the acute care and long-term care setting. And there's some early evidence that bullying is also related to the development of musculoskeletal disorders, such as back injuries, especially when you also have exposure to risk factors associated with manual handling. So what's this relationship between type 2 and type 3 violence then? Well, we know that this is directly related to a poor organizational climate of safety, especially when that climate of safety is just focused on patient safety and not worker safety. In behavioral health facilities, there's been research that looks at co-worker bullying, and where it's allowed to flourish, they see an increased rate of patient aggression and violence. And then for healthcare workers exposed to both types of violence, there are long-term negative health consequences. That's no surprise there, but especially where there's a lack of post-exposure support. This is supervisory and or co-worker support. And we've known for quite a while in safety that when you don't have support from your supervisor and you have an injury with time away from work, you actually take more time away from work and you have less chance of coming back to work, because you don't have that support. We also see a higher intent to leave the job. So there's a direct health impact and turnover impact there when we don't see that supervisory support after exposure to violence.